In our study, we looked at agents given after progression on lenalidomide maintenance, and again, dividing up the group somewhat differently, we found a trend for a better response when a triplet was used after lenalidomide with daratumumab or ixazomib or carfilzomib. I think all these studies give a flavor, too, for a question we haven't had the answer to for a long time, is what if you just take a patient who's on low-dose lenalidomide maintenance and increase the dose to the dose we use for active treatment, not just maintenance, and add steroids. And if you pull that data out of these papers, including ours, you get somewhere between 7 or maybe 9 months benefits. So there is some role to buy a little time, but it doesn't compare with using the more active triplets or changing or including another class of drugs. I think this issue, too, of how you manage patients on lenalidomide maintenance has been addressed by 2 of our MCRN trials. Dr. Venner reported in a poster an update on the MCRN 003, also the CCTG MX1 trial, that showed that patients, by and large, who received KCD, carfilzomib cyclophosphamide index, now it's not just first relapse, but there was a very respectable, almost year-and-a-half progression-free survival in those patients. So this is a useful Canadian-based regimen, and Dr. Sabag has presented in a poster the first results of the MCRN 004 trial, which in patients eligible for funding for pomalidomide were randomized either to daratumumab, cyclophosphamide, and dex with pomalidomide at the beginning or pomalidomide added only at progression. Now, we tend to think the more drugs, the better, but there are cost issues involved. Pomalidomide's an expensive drug, Dara is an expensive drug, cyclophosphamide and steroids are not expensive. And one part of this study was determining that just having daratumumab cyclophosphamide index gives almost a year progression-free survival, which is better than single-agent single-agent daratumumab. So we're trying to sort of define what regimens are useful, affordable for this important group of first relapsers on lenalidomide maintenance.